بسم الله والصلاة والسلام على سيدنا رسول الله وعلى آله وصحبه ومن والاه. Today I would like to speak in a small thing, يعني إن شاء الله to not be long, but it's about this lovely subject, why we hate ROTEM. This is me, your host, Dr. Ibrahim Halawani. I'm be honored by your existence. So some may think that ROTEM is quite complicating thing. But is it really, is it that complicated? I believe that this problem is mainly arise because most of the time when you go to interpret or to read about the ROTEM, you go into a lot of complication and application and a lot of data that really you will find it very overwhelming. But let me ask you a thing. Are you familiar with this gentleman? This scientist, his name is Sigurd Anderson. I'm pretty sure that you're not familiar with his work or his nomograph, this one. But I am also pretty sure that when you find a patient, if you are working as an intensivist or anesthetist, you find a patient who has a severe base deficit, for example, you will give him bicarb. But you don't know the theory behind this. It was the work of this gentleman. So I'd like to separate two things. That when you know the machine of ROTEM, you might go overwhelmed with the interpretation of the ROTEM, the angle, why we have the angle, why you have blah, 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 all this stuff. And all the studies, is it algorithm, which one we go through, what is the all types and all of this, and you will find yourself in an endless circle of a lot of things that you don't know where to start or where to end. Today, I am coming to you to help you ease this thing. Simply speaking, let's go to the core of the clinical application. The clinical scenario you are facing, you have medical bleeding in your patient, and you want to make sure, is this really a medical bleeding? Do I need to correct? And how should I correct? Protamine, if you are open heart. You should give platelets, you cryo, FFB. What you should go through, okay? Here comes the role of ROTEM. It helps you to fulfill this scenario like Superman arrived to save you, okay? How it will save me? ROTEM gives you only, simply speaking, away from everything. When you open ABG, you see pH, you see the BO2, you see the BCO2, and you are dealing with every parameter of it, okay? Also, when you have ECT, you know that this blah, 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 and all this stuff. ROTEM gives you, simply speaking, gives you just four values. The ratio between heptem and entem, extem, and feptem A5. I don't want you to go through a lot of details. Just simply, ROTEM is doing four modules. These four modules, feptem and extem and entem and heptem. 1, 2, 3, 4. There is additional, don't bother yourself. But these four modules give you four data. Feptem A5, extem A5, extem CT, entem CT versus heptem CT ratio. So far, it's very simple. So far, good. خلاص. From this value, what I can do? Simply, now you are suspected you have a medical bleeding. The surgeon said I have medical bleeding, and you do the ROTEM. ROTEM will give you this very simple, very straightforward thing. See the ratio we just spoken about. If the ratio is high, more than 1.25, this means probably you need extra protamine. If feptem, fibrinogen, feptem is less than 13, means your patient does not have enough fibrinogen, so give cryo or give fibrinogen. Extem, which is external busway, don't bother yourself. If the patient with extem is only low while his feptem is normal, خلاص, go and give platelets. So if your patient extem, all of these values are normal, then extem CT is more than 80 minutes, clotting time, this patient need FFP. So you take it one step at a time. See the ratio? Protamine? No, I'm fine, no need. Feptem, fibrinogen, is it low? So I should give cryo or fibrinogen? I correct, I'm fine. Extem A5, while this one is okay, خلاص, I need platelets, I'll give platelets. Then the CT or the clotting factor of the extem, is it high? So I need to give FFP. If all of these are normal, you shouldn't give anything. You start with 1, 2, 3, 4. خلاص, all of them are normal. You will say, my dear surgeon, I assume that you should do a new surgical assessment of the situation, because I believe, or I am inclined to believe, that there is no medical bleeding disorder in this patient. Okay, so to take home message, this is very brief. It's so simple. Like you have point of care ABG, you have point of care ACT. ROTEM is the same. Simple test. Give you simple numbers about data, about how much is the platelets, how much is the cryo or fibrinogen, how much is the clotting factors for you, and how much did you reverse the heparin. Simple numbers lead you to proper transfusion and to avoid to give more or avoid to give less. Or, for example, you give FB while the patient needs platelets, and all of this stuff we are facing in our clinical scenarios. That is all. Keep safe, keep updated. With all my love, Dr. Ibrahim Halawani, cardiac anesthesia consultant. وجزاكم الله خيرا والسلام عليكم ورحمة الله وبركاته.